morning to all of you. A warm welcome to the Zoom webinar organized by GMOA and Society for Health Research and Innovation. We are glad to inform that each participant of the CPD webinar will be receiving an e-certificate for the participation. And please stay with us until the end of the session and we will be releasing the link in the chat box. Now let's move to today's topic. Today's topic is how much we know about oxygen and oxygen therapy for COVID-19. Kindly mute your microphone and turn off the camera during the presentation and use the chat box to clear your doubts at the end of this session. Now, it's my pleasure to introduce today's speaker, Dr. Anthony Mendis, Consultant Critical Care Medicine, currently attached to the National Hospital of Sri Lanka. Thank you for joining us today, and the floor is yours.
Good morning, everybody. I'm Dr. Anthony Mendis, Critical Care Consultant at National Hospital, because that is the most important topic today worldwide, and then it's in crisis of oxygen in Sri Lanka with the COVID. So this is, I think nowadays everybody is talking about oxygen, but I thought of gives a little information about oxygen, because you have done your O-levels, A-levels, and in the medical school, but most of the people forget all the information about oxygen. So this is the most important. This I thought of give a little information about oxygen. So we are going to discuss physics, physiology, pharmacology. That is the easiest way to classify or divide these topics, right, into these three groups, and then the later oxygen therapy. Right. So oxygen is one of the most abundant chemical element on Earth, and then one half of the Earth crust is made up of chemical compounds containing oxygen. One half of the Earth's crust is made up of chemical compounds containing oxygen. 1/5 of the atmosphere is oxygen. Oxygen is a colorless gas found in air, but it is pale blue liquid when it is in the liquid form at very low temperatures. And this, the most important sentence here is life. This is one of the life sustaining element on Earth, and it all the animals need oxygen for their life. And then it was discovered by Joseph Priestley in 1774, and Lavoisier named this gas as oxygen. And it is a misnomer because this oxy means sour, so it is not a sour taste gas. It's a tasteless gas. And then so this in physics topics, I thought of give a little description about oxygen, manufacturing oxygen, storage and oxygen pipeline, oxygen flow meters, monitoring pulse, the widely using monitor pulse oximeter and arterial blood gas analysis and oxygen therapy. In very briefly. And in the physiology, there are a lot of things can be discussed about oxygen, but I choose only four topics: oxygen cascade, oxygen dissociation curve, hypoxia, and oxygen toxicity. And pharmacology, prescription of oxygen, because this is a medicine. Therefore, we should be able to properly prescribe oxygen, and we should be able to discuss about pharmacokinetics and pharmacodynamics as well. And this whole thing is for general medical. My target group is general medical doctors, just post intern, not for very experts, but because I'm discussing these things very briefly to increase your enthusiasm about oxygen, because it's nowadays everybody is talking about oxygen, right? So method of oxygen production. So this is the photosynthesis is the natural way of production of oxygen. I think that play a big role in the world. The fractional distillation is the commercial level, the large producing large amount of oxygen, and then the separation methods like oxygen concentrators and by chemical reactions. This method is also used to generate limited quantities of oxygen, mainly in submarines, aircrafts, spacecrafts, when their oxygen stores are depleted. And then the electrolysis of water, that is very easy way of producing oxygen. If you can put 2 electrodes into water and connect it to battery, you can see air bubbles coming from both leads, and the one is hydrogen, one is oxygen, the pure hydrogen and oxygen. But the problem is we have to use a lot of energy. So this is therefore it is not economical at all. This is the technique of oxygen concentrator. We trap nitrogen from the air, and then we have to use rest of the things. And then main problem here is it has some impurities. And then we can achieve only low flows, about 6 liters, most of the oxygen concentrators. This is a black box. You don't see what is happening inside. There are chemicals that trap nitrogen inside, right? So this when we store oxygen, most of the time we store in oxygen cylinders, and there are color coding system, but there is a slight difference in some countries. So international standards, we use international standards. So you can see different types of gas cylinders, different color coding. And then when you store oxygen in cylinders, so the different sizes has different capacities. So you can see this J cylinder, 57 inches. It has a capacity of 6,800 liters. So you know this, sometimes we use high flow nasal oxygen. That is the mostly used oxygen device nowadays for COVID. But unfortunately, it uses a lot of oxygen. So this, if you use this J cylinder for high flow nasal oxygen, it uses about 6 liters per minute. This, if you calculate this thing, this cylinder is only cylinder is enough only for a couple of hours. So about 100 to about 110 minutes. So this is the solution for that problem. So either you store oxygen in liquid form or cylinder banks. So this is even this. If you all are working in the National Hospital of Colombo, so you can see this liquid oxygen tank near the dermatology building, and then because most of the places is oxygen cylinder banks are in closed rooms. because people cannot enter without proper permission. And then this oxygen usually transport to the wall oxygen ports, and then where we use in theaters by pipelines. So this what you know, I think you must know about the pressure here. That is the only thing I feel you must know. This, it's 4 bar. So 1 bar is 1 atmospheric pressure. This has about 4 bar. And then the oxygen ports on the wall. So this ultimately this oxygen comes to the using side by these oxygen ports. You can see these things in your wall oxygen and walls and in theaters. And then this finally this once it is coming out, so we can see we use oxygen flow meters to check the oxygen flows. So we can see even in what you can see this oxygen flow meter attached to oxygen regulator. Why you say it's oxygen regulator? Because these cylinder gases are cylinder gases are regulated and coming out, because this, you know, these cylinders containing oxygen, how much what is the full capacity of the cylinders, how much of pressure inside the fully filled cylinder. It is about 137 bar. So the 137 times of the atmospheric pressure. So you can see that from this oxygen, this pressure gauge, and then it comes to this flow meter, usually calibrated about 15 liters. You can give about 15 liters, and then this oxygen goes through this humidity water bath. This will add some water vapor into the oxygen. That will reduce, because this, if you give oxygen, dry oxygen, that will dry up your mouth and the respiratory tract. That will prevent to some extent with this humidification. And then this other side, we can see this oxygen flow meters in anesthetic machine. And this oxygen monitoring before delivered to patients, usually done in anesthetic machine. It is with most of the people, I don't know whether you all know about this thing, but anesthetist knows. These are the oxygen analyzers: paramagnetic oxygen analyzer, fuel cell oxygen analyzer, oxygen electrodes, mass spectrometer, Raman spectrograph. Here, all respond to oxygen partial pressure, not concentration. Therefore, the output changes with barometric pressure. So right. This is the pulse oximeter. I thought of discuss a little because this is the widely used monitor in the world. That is the most important monitor. We can see three main characteristics in this pulse oximeter. So this this SpO2 level, this SpO2 is 98 here. Pulse rate is 101, and then the pulse waveform. So this, why you say this SpO2, plethysmographic oxygen. Don't get confused with saturation. This is this is also saturation. It is all right, but here why you put SpO2 is plethysmograph. So it measures this pulsatile waveform in the finger and give this reading. So without pulsatile waveform, you don't get this thing. Therefore, this pulsatile waveform is very important to interpret the correct values of this pulse oximeter reading. And then even nail varnish can interfere with readings. And then it is other thing you must understand is this is this instrument is not calibrated very low oxygen level, because in human studied with animals, but because it is not ethical to research on low levels, right? Therefore, we don't consider very low oxygen values are correct in this pulse oximeter, but it's more than, if saturation more than 85 is usually accurate readings, right? Then little bit of arterial blood gases. There are a few rules of if you want to quickly assess the blood gas. Straight away you look at the pH. If it is less than 7.4, it's acidosis. More than 7.4, alkalosis. Ideally, this the normal pH is 7.35 to 45. So you can take it outside these values also. If you see acidosis, then you check with the carbon dioxide. If carbon dioxide is high, that is respiratory, and then look at PCO2 and bicarbonate, both things. If carbon dioxide is high, then it is primary respiratory acidosis. If carbon dioxide low and bicarbonate is also low, the primary metabolic acidosis. But here, most important thing, I usually check each and every blood gas standard bicarbonate, because standard bicarbonate doesn't change with respiratory component. If there is a change in respiratory, if there is a change in metabolic component, if standard bicarbonate is usually 24, if it is more than 24, it is likely to be alkalosis, metabolic alkalosis. If it is less than 24, it is metabolic acidosis. So sometimes you can easily identify mixed pictures with when you check the standard bicarbonate along with above readings. And then when we discuss about physiology of oxygen, I choose only these 4 topics: oxygen cascade, oxygen dissociation curve. I think you all have studied in your medical school, and then for your postgraduate studies, these things. But I want to give a little description about these things, right? And this is oxygen cascade. So this is oxygen cascade is step down reduction of oxygen from air to mitochondria. So you can see dips at different levels. So this this atmospheric oxygen has pressure about 750 millimeters of mercury. So this we breathe 20% oxygen. So that means we breathe 1 liter of oxygen, and then the partial pressure should be 150, because this 1/5 of 750, right? That's how we calculate. So this 150, but you see this the 150 become 100 when it goes to alveoli. So this is because of water vapor, and it mixes with expiratory carbon dioxide. So then again we can see dipping capillary arterial levels. So yeah, because this first dip is diffusion, because this gas has to diffuse from alveoli to arterial blood through alveolar capillary barrier. So there is a little drop in that, and then when it goes to arterial circulation, there are shunts. So this intracardiac, extracardiac shunt can cause little. These alveolar to arterial, these differences can contribute to a gradient. We measure most of the time it is about 5 to 10 most of the time. And then when this blood goes to transported to tissues, and tissue extract oxygen, and then you can observe further drop in partial pressure in mitochondria. And then the next thing is physiology of oxygen dissociation curve. Right. This curve is a sigmoid shaped curve. We know this oxygen has affinity, very high affinity towards hemoglobin, because it has four molecules, usually 4 molecules attached to hemoglobin. But when first molecule attached, it increases the affinity to the second, and then the third. So this the same thing happen when dissociation of oxygen from the hemoglobin also. That's why this sigmoid shape. And there are 3 salient features you can observe in this oxygen dissociation curve. Simply we call it ODC. The arterial point, venous point, and P50. Here, this graph has lowered as arterial point. It has come down to 88 because of some problem, and ideally it should be about 98 to 100. And then the venous point has venous point means venous blood oxygen saturation. It is 75%, around 75%. And then when you go back, when you come to the x-axis, this is partial pressure of oxygen. This is 40, right? And then arterial 98 saturation 98 100, and it should be again partial pressure about 100. Right. And 50%. Right. The next point is P50. This is P50 is the partial pressure of oxygen at 50% saturation. This is usually 27. This point is defined because we need to describe the left shift and right shifts. For the description for these purposes, we define this point. So if there is a left shift, high pH, low 2,3 dpg, low temperature, so there is a left shift. The problem with the left shift is it can extract oxygen from blood, lungs to blood, but the problem is because of this high affinity, tend to release oxygen at tissue level is very low. So this but this the opposite is happening with the right shift. Low pH to high 2,3 dpg and high temperature, fever. At that time, oxygen releases more at tissue levels. So these are the important things with oxygen dissociation curve. And then I thought discuss a little about hypoxia. Hypoxia is actually this tissue level oxygen starvation. So there are 4 types of hypoxia: hypoxic hypoxia, anemic hypoxia, stagnant hypoxia, and histotoxic hypoxia. The hypoxic hypoxia, you have little oxygen or the low oxygen in the inspired gases, and ultimately low oxygen in the blood. So this hypoxemia is evident with this hypoxic hypoxia. And anemic hypoxia is less hemoglobin, available hemoglobin to transport oxygen. So this is anemic hypoxia. We can see that in the carbon monoxide poisoning, because this the less hemoglobin available for transport oxygen, and in the stagnant hypoxia, the oxygen is not transported properly to tissues because of this poor blood flow or poor cardiac output, maybe in the heart failure. And the histotopic hypoxia is because there are enough oxygen but cannot utilize, because like cyanide poisoning. Right. So this when we give oxygen, this oxygen toxicity is also very important topic. Nowadays we are giving oxygen for lot of patients, and then I say this too much of anything is not good. Even oxygen, the oxygen free radicals are formed even at physiological level. However, they are scavenged by antioxidant mechanisms like enzymes, superoxide dismutase, catalase, glutathione peroxidase, pentose monophosphate shunt, like antioxidant pathways. And when there is when this capacity exceeded, usually this will happen. Usually this FiO2 more than 60%. That's why we try our best to reduce the FiO2 using different techniques until about 40, 50, 60 like. So this if this capacity exceeds, this free radicals are accumulating and oxidative damage to CNS and lungs. However, we should not let patients to become hypoxic due to fear of oxygen toxicity. So that is the other thing, because I don't like to say oxygen toxicity, because some are reducing oxygen a lot, but we have to have a balance of giving oxygen also. And then if there is a oxygen toxicity, so you can see so this signs symptoms that in eyes, visual field loss, nearsightedness, cataract formation, bleeding, fibrosis, twitching, central nervous system seizures, respiratory system, jerky breathing, irritation, coughing, pain, shortness of breath, tachybronchitis, and acute respiratory distress syndrome. And then in the pharmacology, there are three topics. Prescription of oxygen. I'll deal with this topic in the oxygen therapy, and we'll see a little about pharmacology. So this, as with all other medications, we start when we are describing any medicine, we start with physiochemical properties. So this oxygen is a diatomic gas, density and viscosity slightly higher than that of air. And then conventionally the wall oxygen has 4 bar. We have discussed that earlier also. And then the tasteless, colorless gas, however, the blue in liquid form, pale blue, and then support combustion. And then administration. So this is a inhalational agent. So we can administer via fixed or variable performance devices. We'll discuss in the oxygen therapy section. And then the ECMO. So extracorporeal membrane oxygenation. So we can oxygenate the blood straight away from the machine, or this like the artificial lung. And then externally we apply hyperbaric oxygen therapy as well. And then absorption. So though we breathe 1 liter of oxygen per minute, say we breathe minute volume of 5 liters, that 20% of 20% is oxygen. So that means 1 liter. So we breathe 1 liter of oxygen per minute. But oxygen consumption is about 250 milliliters per minute at rest. But so this the 7 we breathe 1 liter but use only 250. There 750 is our reserves. So we have huge reserves. And then there are evidence that cutaneous absorption as well, but 1 liter, but it's very insignificant amount. Anyway, there is the tension difference between the skin oxygen tension and the air also, that will diffuse a little light, but it's not like frog. Frog has a huge capacity to absorb oxygen from its skin, but no evidence of other routes. Metabolism. This oxygen is metabolized in all tissues in all tissues for energy production, mainly brain, skeletal muscle. Not only these things, so each and every cell need energy. So this for oxygen is used for aerobic metabolism, and mainly metabolized in the mitochondrial enzymes, and the zero order kinetics mainly metabolized to carbon dioxide and water, cleared via lungs and kidneys. And then indications for use. This is actually for when we are discussing any drug. So we say we discuss about indications. So the supplementation of hypoxemia, hypercapnia, these things also we give oxygen. And then the prophylactically we pre-oxygenate patients. Pre-oxygenation is the same. Is denitrogen is also we can use for anesthesia. This pre-oxygenation, denitrogenation, almost same, because this as an antidote for carbon monoxide poisoning, and we use therapeutic as an antibiotic, hyperbaric oxygen for deep anaerobic infections. To decrease the volume of air-filled body cavities. If there are body cavities, because this it usually tend to fill with nitrogen, and then even pneumothorax, pneumoencephalus, so air embolism, we used to give high amount of oxygen to absorb, and then this oxygen tend to go into those cavities and then absorb into the body. And then the management of decompression sickness. We know this divers goes deep in the sea, and then when you go deep in the sea, their nitrogen get dissolved in the blood, and it comes out as bubbles when they come to the surface. So it is very painful condition. We call it bends. And then we have then we have to recompress them with and giving hyperbaric oxygen. So that is the treatment for decompression sickness. And then the contraindications for high FiO2, because it's not real, but it's you can't say contraindications. This is relative contraindications. Bleomycin is an anti-cancer medication that can cause pulmonary fibrosis. This believes that this high oxygen contributes to this fibrosis, and this is the same in the paraquat and aspiration, paraquat poisoning and aspiration. Anyway, you can't say you can't give oxygen, because this we have to prevent high oxygen as much as possible. It's a relative contraindication, but these complications. So this drying of mucous membrane is one mentioned at the top, because this, if we give dry oxygen, so that's why we need to humidify oxygen. Inflammatory tracheobronchitis, and then central respiratory drive. So this is a problem when there is a hypercapnia and the carbon dioxide retainers like COPD. Their oxygen drive, this respiratory rate, respiration is mainly depends on the little hypoxic drive. So this that is also a complication if you give 100% oxygen. And then the absorption atelectasis is loss of splinting, because you need to maintain you need nitrogen filled in alveoli also, because this if you fill the whole alveoli with oxygen, once it is absorbed into the circulation, the alveoli get collapsed. So that is also another problem. And then left to right shunt in ASDs, increased peripheral vascular resistance, cerebral and coronary vasoconstriction, euphoria, retrolental fibroplasia is a very famous in newborn babies when kept in incubators, and decreased erythropoiesis. And then oxygen therapy. So this is so this lot of people are now patients are getting oxygen therapy. This now it is becoming more and more, and then the oxygen stores are now depleting, and then the country is going to be a oxygen crisis. So we'll see how we try. Why you need oxygen therapy? So for hypoxia, hypoventilation. So these hypoventilation patients, just after surgery, we give oxygen to remove few amount of carbon dioxide that will take the increase the oxygen compartment. And then the pre-oxygenation or denitrogenation in anesthesia. And then the most important nowadays, we see increased work of breathing, high oxygen consumption in these COVID patients, right? And then what is hypoxia? The diminished availability of oxygen in the tissue level. We have discussed this thing. These are the causes. This indirectly, these are the same with the low oxygen, FiO2. This means hypoxemia, anemic hypoxia, and then the circulatory failure is stagnant hypoxia. The cellular dysfunction is histotoxic hypoxia. And then so this oxygen delivery to tissues depends on two factors. So anyway, oxygen delivery we call oxygen flux. So this oxygen flux depends on oxygen content of the blood, amount of oxygen in the blood, and the pumping power, cardiac output. Anyway, this all the factors affecting cardiac output can affect the oxygen flux. So this that means what are the factors of affecting cardiac output? Preload, afterload, contractility, heart rate. All these factors can affect the delivery of oxygen to tissues. So this, then what is oxygen content? Oxygen content is depends on saturation of oxygen, hemoglobin, amount of hemoglobin. If this anemic patient has low oxygen content, and the C is a constant, depend on the amount of denatured oxygen, hemoglobin, and then like methemoglobin. There is a constant number 1.3, like there is a constant number, and the D is dissolved oxygen. These are the things that can affect oxygen content of the blood. And then what is hypoxemia? Anyway, hypoxemia is low oxygen in the blood. So but this objectively we have to get some numbers. So this decreased partial pressure of oxygen in the blood below normal range we call it hypoxemia. This we usually take PaO2 less than 60 or saturation less than 94% in subjects breathing room air, and low plethysmographic oxygen less than 92% of pulse oximeter with oxygen supplementation. And then how to identify a critically ill patient. Before giving oxygen, we must identify critically ill patient, because this if there is a critically ill patient, we usually put oxygen before doing all the things. That's all. So this before that you have to check the vital signs, ABs, airway, breathing, circulation, and disabilities, and even Muse scores you can check to identify critically ill patient. And then once you've identified critically ill patient, so this is the Muse chart you can use, but this nowadays it is very difficult for COVID patients, even this type of monitoring. But if we can monitor these Muse charts, you can optimize the management. And then how to detect the out of these critical ill, how to detect hypoxic patients. So this you need to clinically assess these patients, right? Then dyspnea. So this is the first thing you have to assess. This respiratory rate is sometimes we can see in the morning respiratory rate is 15. About 2 hours ago it is 20. Now it is 25. So you see this patient is getting dyspneic. So at this stage, this is actually type 1 respiratory failure. Now patient is compensating by increasing the respiratory rate. So at this stage, we must detect all these things, and then if patient has altered level of consciousness, another way of suspecting hypoxia. And this cyanosis is pretty obvious. If there is a cyanosis, the patient is hypoxic. And then therefore, so we have to use this pulse oximeter to check the partial pressure of oxygen. And then the more invasive thing is arterial blood gas or even venous blood gas. We can get idea. And then if we monitor the modified early warning scores, it's very helpful to detect these hypoxic patients. And so before giving oxygen, we must know, because now oxygen is we have to preserve oxygen a lot. So this we should not give unnecessarily oxygen. So check whether before giving oxygen, we have to document if there is a documented hypoxia. So this, if there is ABG evidence, give oxygen. And even actually, clinically we can give oxygen, but if there is if we are giving unnecessary oxygen, we can put them on air by using these ABGs. And then high work of breathing, COVID pneumonia, we can see respiratory rate is going up, high work of breathing, and it's short of breath, and severe asthma, head injury, hemorrhage. Sometimes without looking at those things, we give oxygen, because this they tolerate hypoxia very minimal. Therefore, before discussing everything, we give oxygen. And acute MI, short-term therapy or surgical interventions, post-anesthesia, recovery, sedation, sedated patients, we give oxygen. And then fear of actually the hypoxia, and then the carbon monoxide poisoning. We have discussed this thing in the oxygen as a medication as well. And then the method of administration. This is the now we have come to our topic, oxygen therapy. So we use fixed performance devices and variable performance devices for oxygen administration. FiO2, here the fixed performance devices, FiO2 is constant. The fraction of oxygen is constant despite changes on the inspiratory flow rate. So this breathing rate, flow rate. So this FiO2 is pretty constant here. But examples are oxygen 10 anesthetic breathing circuit, high flow nasal oxygen, Venturi mask, face mask with reservoir bags. So we'll discuss one by one. And then even this helmet. So this I found this picture because this high flow nasal oxygen connected to the helmet. So this is also another fixed performance device. And these are the Venturi masks. We can see different colors and different colors for different FiO2. And there is a flow rate mentioned in the this device. So as far as we are giving adequate amount of flow, this FiO2 is fixed to that percentage. So this Venturi mask mixes with room air and creating high flow enriched oxygen to a suitable concentrations, provides accurate and constant FiO2. Typical FiO2 delivery settings are 24, 28, 31, 35, 40, 60. Right, but it's difficult to give oxygen more than 60% FiO2 with Venturi mask. So then we have to find other options. So this is the next option: face mask with reservoir bag as a non-rebreathing mask. So this oxygen get filled in and this reservoir bag at the peak of the inspiration. We know this our inspiratory our peak inspiratory flow rate about 35-40. So this but if we give usually we can give with the normal flow meters about 10 to 15 liters. So it is not enough for peak inspiration. So so the rest of the oxygen can be taken from this mask. That is the technique of this face mask with reservoir bag. We call non-rebreathing mask. So it can we can use 6 to 15 liters like, and then can achieve 80 to 100%. It's maybe 90-95%. Advantage here is delivers highest possible oxygen concentration and suitable for breathing spontaneous with severe hypoxemia. So this so you can increase the oxygen without intubating or without CPAP to some extent. And then the disadvantage is impractical for long term, and then malfunction can cause carbon dioxide building up. And then high flow nasal oxygen. You can see this nicely smiling face because he is experiencing the comfortable comfortability of this high flow nasal. So these are the high equipments, the apparatus set up here with high flow nasal. This is the cannula, high flow cannula. This is the heated hose, and then this machine delivers. This is the humidifier. It can add some water vapor into the this breathing circuit. and this is the flow meter. This can deliver high flow up to 60 liters per minute. So ultimately, this high flow device can give humidified warm humidified oxygen up to 60 liters per minute, and with some small peep. So this is flow peep because of this very high flow. And then variable performance devices. The variable performance devices, we can use nasal cannulae and simple face mask. And this is the appearance of a nasal prongs or nasal cannulae. This is how you use it for your face, and this is the closer view of nasal prongs. And then it can deliver 24 to 44% of flow rates, but we don't usually go beyond 4 liters per minute. So if we want more than that, we usually put patients on Venturi mask. If it exceeds more than 60, we usually go for non-rebreathing mask or the other modalities, right? CPAP or other invasive modalities. And then the nasal cannula. The patients, the advantage of this nasal cannula is you can talk and eat with oxygen in place, and easily use in home settings. Disadvantage is there are disadvantages, but may cause irritation to nasal mucosa, and then and it delivers only low flow rates. It's not reliable high flow rates, right? And then simple oxygen mask. Simple oxygen mask is made up of clear, flexible plastic or rubber that can molded to fit the face. It is held to the head with elastic bands. Some have a metallic clip to fix over the your bridge, nasal bridge, and then this delivers low flow rate 6 to 10 liters. Even you can put 15 liters also, but you have to have a good seal around the mask. And the disadvantage is the tight seal required to deliver higher concentrations. And then advantage is you can give oxygen for a short period, right? How to set up oxygen therapy. So this is very important, because we discussed that in the pharmacology section, the prescription of oxygen. Before prescription of oxygen, we have to set up our targets. So then either 92, 94, 98, 96. So that depends on the patient's condition, and then determine how much. So percentage, FiO2 60%, 50%, or 40%, like, and then what device to use. So these high flow nasal prongs, like, we have to write down, and then on how to monitor. So if you put oxygen, and then we have to write down the pulse rate, respiratory rate, or whether we are going to check ECG, and the BP, blood pressure, partial pressure oxygen, and how frequent this should be done, half an hourly, quarter hourly, like that, right? So this I thought of setting up a target, discuss a little. This are we going for 100% oxygen? This is the problem I have seen most of the places. Everybody is target for 100% oxygen. So this is I think no value, because this sometimes you might giving too much of oxygen, because 100% pulse oximeter reading means it can be partial pressure of oxygen 100, 150, 200, 300, 400. We don't know. So this, but if we maintain 80, 98, 99, so we know this partial pressure oxygen is around 100. Therefore, this in all acutely unwell patients not at risk of type 2 respiratory failure, recommend target saturation is 94 to 98. If it is more than 90, 94, it's enough. And then most of the COVID-19 patient, our target is about 92. So this is, but this varies between patient to patient because of this high oxygen demand, high oxygen consumption. If you set up a high oxygen target for COVID patient, you have to give a lot of oxygen. So this, and in patient at risk of type 2 respiratory failure. So like we mean this like COPD like patients. Some patients are carbon dioxide retainers. Their brain stem is insensitive to carbon dioxide. So this respiratory rate is maintained with little hypoxic drive. So that patient, if you give too much of oxygen, the respiration may go down. So therefore, that type of patient we target 88 to 92 range. The recommendations are all acute ill patients should be monitored for oxygen saturation. Amount of oxygen should be recorded with partial pressure of plethysmographic oxygen or the arterial oxygen. So ABG or pulse oximeter readings. And if oxygen requirement is going up or SpO2 is going below 85%, you have to seek expert help. You can't wait and doing that thing, these things. You have to get advice from intensivists or these anesthetists. They are the people dealing with these airways. And too early ABG and full blood count in significantly hypoxic patients as general. And then the pulse oximeter should be available in all the places where critically ill patients are managed. And following devices should be available. Check whether you all are managing COVID patients, nasal cannula, non-rebreathing face mask. Very important nowadays because you prevent unnecessarily giving too much of oxygen. And then wide range of Venturi mask, 28 to 60% range, and then high flow nasal oxygen if available. It's very costly machine nowadays because it uses a lot of oxygen. It is discouraged in most of the places. And then CPAP and BiPAP, invasive or non-invasive for COVID-19 patient, if possible, if it is available. And then the last thing I want to tell you, this COVID patients, recently recovery RS trial finds CPAP reduces invasive ventilation in COVID-19 patients. This was published on 5th of August 2021. This is last week, right? This is the, therefore, this is now the for COVID patients for oxygenation purposes, CPAP or little BiPAP is very beneficial when compared to invasive ventilation. These are my references. Thank you very much. Yeah, so I have to put questions.
Thank you very much, sir, for that great presentation. And we have got ample of questions from the participants. I would like to summarize the questions and repeat to you, sir. And the first question is, what is the accepted brand of pulse oximeter?
So I don't use brands. So this what is available I use, because so we don't promote brands. So we go for usually even for medicines. Senaka Bibile doesn't like prescribing in brands, right? That's the answer.
Thank you, sir. And the next question is pulse oximetry reading affected by the incident light?
Sorry?
Is pulse oximetry reading affected by the incident light?
There are discussions, but exactly I can't comment on that.
All right, sir. And the next query is, should we use only sterile water for humidification of oxygen, or can we use normal tap water to humidify oxygen?
Because that is a problem, because even for saline nebulization, because we put them into a small container and then they connected to the or these breathing circuits that can introduce some infection. Therefore, it should be very sterile manner, right? Because therefore only when it is required. So if you are nebulizing with bronchodilators, you can add some extra saline and nebulize, right, for humidification. Right.
Thank you, sir. One more query from a participant. Can we get central nervous system toxicity by inhaling 100% of oxygen at 1 atmospheric pressure? So it has to be more than 1 atm.
Yeah, because we are giving 1 atmospheric pressure oxygen even for 100%. So this, but if there is a great problem, even we can go for 3 atmospheric pressure for hyperbaric oxygen. So this this can happen even at 1 atmospheric. So that's why we usually reduce the FiO2 to 50 to 60%. We try our best to reduce to that level, because up to that level body can handle oxygen free radical formation, because it's oxygen free radical formation you can see even at normal level, but those free radicals are scavenged nicely with this antioxidant mechanism. The body has it's a big capacity. Up to 60% means very big capacity. If it goes beyond 60%, these free radicals get accumulated and can cause these damage central nervous system and lungs. Main problem is this when lungs affected and lung damage with the oxygen free radical, that will increase the oxygen requirement further. Then we get into vicious cycle. So this is very difficult to come out from that vicious cycle.
All right, thank you, sir. And the next query is, what is the alarm of oxygen saturation that should be set in a pulse oximeter?
So pulse oximeter, actually this that depends on the patient, because this as I described, that setting up FiO2, that is also same, because this so you can't exactly say this is the level, because that depends on the patient oxygen requirement and then the oxygen tolerability. But recently I have seen this one patient, COVID patient. He because he's on CPAP ventilation, 100%. He is getting 100% with CPAP, and but when he is getting his feeding, it tend to go down to even to 60s, 70s. But he is fine. He is tolerating that thing. because these target levels differ from patient to patient. Right.
Thank you, sir. A few more queries we got. Please bear with us. Yeah, sir, pulse oximetry readings are affected by bilirubin levels?
It was described earlier. I don't know the recent evidence.
All right, sir. And one more query, how to use pulse oximeter and ABG in carbon monoxide poisoning?
Because carbon monoxide overreaches the pulse oximeter reading. Therefore, we should not rely on this nice oxygen saturation in the pulse oximeter for carbon monoxide poisoning. And then the opposite thing happened with the methylhemoglobinemia. It tend to give low oxygen reading always, right?
All right, thank you, sir. And a few more questions. Can you please explain a little about how to choose CPAP and the BiPAP? I mean, CPAP was
right. Yeah, CPAP mainly we use PEEP and ventilate patients, right? But it's I have seen this most of the COVID patients. They need little BiPAP because they are need some pressure support and supports the ventilation to remove carbon dioxide. So this the BiPAP is if there is any bi means 2, so there is a upper level and lower level. The upper level is the pressure support for spontaneously breathing patients, and the lower level is PEEP. We can put PEEP and pressure support. That is BiPAP for spontaneously breathing patients.
All right, thank you, sir. We got a few more queries. I'm trying to connect the questions and asked from you, sir. Can you explain when a patient gradually deteriorating step by step, what devices we should use?
Right. That's a good question. Gradually deteriorating patient. So that's why I discuss a little about this how to detect critically ill patients and how to detect hypoxic patients. So that's why because these Muse charts modified early warning scores, Muse charts are used at National Hospital. A lot of wards have these things, but unfortunately the heavy load of COVID patients, we can't monitor this use these Muse scores. The huge amount of work, but if we can follow these things, very easy to find critically ill patients and the gradually deteriorating patients. And for this, when they are deteriorating, we should be able to catch them early. And then when giving oxygen also, if oxygen requirement is low, we can use nasal prawns, and if it is more up to the 21 to 28%, I use nasal prawns, and if it is more than 30 to 60 venturi, and it's more than 60 high flow this breathing non-rebreathing mask, and then along with plus or minus CPAP, BiPAP, high flow nasal oxygen, and invasive ventilation thereafter.
All right, thank you so much, sir. I think that's all the queries. I would like to thank Dr. Anthony Mendis for his excellent presentation and spending his valuable time with us on behalf of GMO and Society for Health Research and Innovation. Also, we would like to appreciation on behalf of GMOA and Sri. Please follow the link in the chat box to receive your participation certificate. That's the end of the webinar today.
Right.
Thank you for your participation. Thank you very much, sir, again. And I'm Dr. Sinta signing off today.